Hi, and welcome to Health Chats with Abington Health. I'm your host, Cahn, and tonight's Health Chat is sponsored by Abington Health in partnership with Philadelphia Magazine. Tonight we're talking about minimally invasive knee options. We're going to discuss knee pain and how to fix it. What are the medical options? And tonight we're talking with Dr. Andrew Starr. Dr. Starr is the medical director of Abington Health's Orthopedic and Spine Institute. Hello, Dr. Starr. Dr. Starr, if you could start first by telling us about your background.
Okay, well, I'm an orthopedic surgeon through Abington Health, which is Abington Memorial Hospital in Abington, Lansdale. I've been there for about 28 years, and I specialize in joint replacement, so I do knee and hip replacements every day, every week.
All right. So I know a lot of people have asked questions, and I thought maybe we should get right to it. This is someone, and again, I want to tell you if you want to ask a question, it's confidential. What are the options someone is asking for non-surgical treatments for my knee?
And that's the first question everybody should ask, which is, what do we do for this patient first? And, you know, a lot of my patients come in and they say, I'm here for a knee replacement. Mm-hmm. And we always stop and say, well, wait a minute. What bothers you? You know, do you have bone on bone? Is it serious arthritis? But also, what have you tried? I had a patient scheduled for a MAKOplasty in about 2 weeks who came to me referred by another doctor, and she was a very appropriate patient. But I said to her, have you tried physical therapy yet? She said, well, no, I haven't. I said, well, do me a favor. We'll put you on the schedule, but go try some physical therapy. And she came back 2 weeks later, or she called me 2 weeks later to cancel her surgery, which in my opinion was a win because she's only 30-some years old, and we'd like to hold off if we can. So the types of things we do are, and your doctor should be telling you this, physical therapy to strengthen the muscles and tendons around the joint, braces, supportive braces, some with hinges, some without hinges. You can try both. Anti-inflammatory medication, the common ones are Advil and Aleve, but there's also prescription ones. Using a cane or a walking stick for those people who are so inclined, and generally people don't really like to use canes, but they really do work. So those are the main things that we do for patients who are contemplating surgery, but we tell them, look, give something else a try first, and many times you can give yourself years of relief and a happy life, continuing to run, continuing to play sports, but modifying your activities a little bit to control the pain.
Okay, Dr. Starr, we just had a viewer write in this question from Bucks County. What is the difference between a standard knee replacement and the MAKOplasty method? I think you covered this a little bit, but maybe you can tell us a little more.
Right. So to go into more detail, total knee replacement is a procedure that's performed in this country approaching 1 million times a year. And it's the complete knee. So the femur and the tibia, which are the upper and lower leg bones, get completely resurfaced. So we put a metal piece on the top, a metal piece on the bottom, and a piece of plastic in between that acts like the meniscus cartilage. The metal basically smooths out the joint so it makes a smooth way to move. Most times we also resurface the kneecap. So the whole joint, there's no longer any parts of the joint that are touching. It's all been separated by plastic and metal. A MAKOplasty, a current MAKOplasty partial knee replacement attacks one of those areas. So if your arthritis is simply along the inner part of your knee joint where it touches the other knee, you can do a MAKOplasty, which is a robotic partial knee. Now you can do a partial knee replacement without the MAKOplasty, but the advantage of the robot is basically a smaller incision, less invasive, and you really get a very accurate reproduction of the surface of the joint. In all partial knee replacements, and I emphasize this with my patients, you save every ligament. So you don't, on a total knee, you're cutting ligaments to get the joint in, and the artificial joint has its own ligaments, if you will. In a MAKOplasty, you don't do that. So these patients really feel a lot more normal. Their knee functions like it's supposed to.
I see. Another question from Philadelphia. In your opinion, is it better to wait as long as possible before having knee replacement? If not, when is the best time considering the progress of osteoarthritis?
Well, that's a great question. There's so many factors that you need to take into account to decide when to replace a knee. The first thing is all the extremes are not right. I don't know how many times I've been told by patients, I was told that I shouldn't have a knee replacement until I'm dying. You don't need to wait till then. What I find is that you really need to look at your activities. If you're having trouble going up the stairs, if you're not going to the shopping mall, if you like to do that because you can't walk, if you can't go and do the activities you want, maybe you want to play some doubles tennis or walk the golf course or go for a hike. You know, these are all the things that patients tell me. So I had a patient in the office the other day who was about 60 years old. And, you know, the questions, if you asked him the questions the right way, he would say to you, well, I can live with what I have. I have severe arthritis. It hurts me all the time, but I can manage. So the question I always ask is, well, what have you stopped doing? You know, what are you no longer able to do? Well, I like to play tennis. I can't do that anymore. I like to go on hikes with my wife. I can't do that anymore. And so I say to the patient, the only thing I can tell you is what it's like to go through with the surgery and whether you have arthritis. What I can't tell you is when it's time. And the time is when it affects your quality of life. And for me, that might be tennis or golf. For somebody else, that might be just going from the bathroom to the living room to the kitchen to get something to eat or walking into the bathroom. It depends where you are in your life and what you're interested in. So the answer is not the same for everybody. One thing that we do know, though, is for every patient who actually undergoes surgery, there's probably 3 or 4 or 5 other patients or people who don't have the surgery because they're afraid of it. And what these new options do is it gives us an opportunity to offer this to people in a less nerve-wracking way, meaning we can be less invasive, we can get you on your feet more quickly. Instead of doing a complete knee, maybe we can do a partial knee in the appropriate set of circumstances.
Dr. Starr, we're about to wrap up. What are the key takeaways that you would like our viewers to leave with tonight?
Well, I think there's a few simple messages. You know, the first message is be your own advocate. If something hurts, if something's bothering you and it's consistent, you know, I'm not talking about, hey, I played, you know, soccer for the first time on the weekend and I'm 50 years old and my legs are sore and you expect that and it goes away after a few days. But if things are stopping you from doing what you want to do, talk to your primary doctor, talk to a specialist like an orthopedic surgeon, and get some idea of what the problem is. The other thing is, though, all of medicine now is moving in the direction of less invasive, higher technology to make these procedures, when you need them, and I hope you never need one, but when you need them, more accurate, more successful. You know, and we just, as physicians and patients, we just don't want surprises anymore. So having this higher technology, having higher success rates, being able to get people up and moving more gives you an option, so you don't have to be quite so concerned about it. So I think those are my 2 messages. Be your own advocate and trust that technology is going to help us to get better answers and better solutions as we go forward in the future.
Dr. Andrew Starr, thank you so much. With Abington Health, thank you for joining us tonight and answering all of our viewers' questions. I'd like to tell you now about our next health chat. It's on Monday, May 4th at 6 p.m. with Dr. Mara Thur. She's an OBGYN with Abington Health, and she's going to be answering your questions about getting pregnant after age 35. And you can sign up and ask your questions ahead of time, just like you did for this chat, by registering on www.abingtonhealth.org/healthchats. On behalf of Abington Health and Philadelphia Magazine, I want to thank you for joining us. Have a great evening.